everyone, and welcome to week 7. This is taking a few seconds. This week, we'll be talking about the ethical dilemmas involved with public health and medical care, why public health is involved with medical care. You will be able to explain at least 3 inequities that still exist in the medical care system today, define the field of dreams effect, and discuss ways outcomes research can improve medical care. This week's assignments include a quiz on chapters 23 through 29, a medical care short-term essay, health insurance blog, issues and health quality research wiki, and of course your discussion board. For the medical care short-term essay, the purpose is to consider the role of the medical care system and the role it plays in public health. For this, you can use chapter 26 in your textbook. You are going to write a 500-word paper to justify the reason why medical care is considered part of the public health system. You can use resources from your textbook as well as other references. And make sure you cite your sources using the APA guidelines. If you need more information on how to cite your sources, please visit Harper's Library. You can also visit the OWL Purdue website for information on APA citing, and I provided the link in the assignment for you. The other assignment is the health insurance blog, and the purpose of this assignment is to consider your own experience with health insurance. Chapter 27 in your textbook may help you with this assignment. And the questions to answer are you covered by health insurance? If you do not feel comfortable answering that question, then you may use a fictitious person. If so, describe the fictitious person plan. Are you happy with what you have? Why or why not? And if not, if you are not covered or your fictitious person is not covered, what are the barriers to being covered by health insurance? So in other words, why is that person or yourself not covered by health insurance? What is preventing you from obtaining health insurance? Then you also have an issues in health quality research wiki. The purpose of this is to research and identify current trends in healthcare research and quality. You are going to visit the website, Agency for Healthcare Research and Quality, review the recent press releases, and I'll show you where to locate that in a minute. And then you're just going to choose one issue or one press release to discuss. For that press release, discuss what is the main issue presented, what is being done about it, and try to choose a press release that no one has already done in the wiki. So make sure you read through the wiki first and then choose a press release to discuss. And so when I talk about press releases and the website, here's the website, the Agency for Healthcare Research and Quality. And the link I provided will bring you right to the press releases. However, if you have trouble locating it, it is located under News and Press Releases. And then here are the press releases in order from most recent down. So choose one here to look at and analyze what is it about, what is it trying to fix, and so forth. Moving on, so now we'll move on, and of course, before I move on, again, you have your discussion board. So for chapter 26, this is talking about how the medical care system is a public health issue. And so why medical care? Why focus on medical care? Well, this has to deal with immunizations, prenatal care, well baby care, testing for risk factors and secondary prevention, treating injuries and illnesses, and it also deals with the failures of the public health world. So when is medical care a public health responsibility? First, it is when it prevents the spread of communicable diseases, as we have the epidemic, although it is changing to an endemic right now with the COVID-19. When we're looking at emergency services, the hospitals are required by law to provide care for life-threatening conditions. Veterans get care in the VA system, and prisoners also have a right to medical care. And how is medical care paid for in the U.S.? So most Americans get health insurance through their employer. There's also charity care, which has been a long-term tradition in the United States. There are public health clinics for communicable diseases. There are community health centers. And then in the 1960s, Medicare and Medicaid passed. However, 20% of the US population under 65 is uninsured. Although our textbook is an older edition, I would say this is probably closer to 12 to 13%, but that's still a significant portion of our population. And the American Medical Association supports increased access to health care for all citizens. So we look at Medicare, and what is Medicare? It is part of our Social Security system. It is mandatory insurance for all workers, and workers and employers are required to pay in for this insurance. Everyone over 65 is eligible. Also, younger people who are disabled are also eligible for this insurance. And there's a couple parts. Part A is hospital insurance. Part B is voluntary. There is a monthly premium, so you will have to pay a monthly cost, but it also covers doctor bills and other outpatients costs. There's also a prescription drug plan that was put into place in 2006. When we look at Medicaid, Medicaid is a welfare program for the poor. The costs for this program are shared by federal and state governments, and eligibility really is determined by the state. So different states have different eligibility requirements for Medicaid. There's also the State Children's Health Insurance Program, SCHIP, for families who earn too much to qualify for Medicaid, but not enough to purchase private insurance. When we look at licensing and regulation, it's the state that licenses physicians, nurses, and dentists. States can also has the power to discipline those practitioners for incompetence or misconduct. And there's also state licensing that regulate hospitals and nursing homes. So as you can imagine, there's lots of ethical and legal issues in medical care. There was the Supreme Court abortion ruling, Roe versus Wade, making abortions legal, and really a decision between a woman and her doctor is what the Supreme Court states. Also assisted suicide, which was really brought to the public's eye with Dr. Jack Kevorkian, who was a doctor who assisted people in committing suicide. These were for terminal patients where there was no hope that they would survive their medical condition. Later on, we have the right to die, and this was really brought to the public's eye with Terri Schiavo. There were a couple other cases. Terri Schiavo is one that I recall. She was a woman who was in the hospital. She was in a vegetative state, and her parents were arguing for her to continue the care so she would continue to live, although again, it was a vegetative state. Her husband was the one arguing against that and wanted to have her taken off the machines and allow her to die. This brought about this obligation to provide futile care. And what this means is providing continued care, knowing that there's really no benefit to providing that care. Abortion, Roe versus Wade, we already talked about. And then what about the treatment of handicapped babies? So this brought about the baby doe rules. And what this says is that doctors must provide all the available medical interventions for babies that have developmental disabilities. Other ethical issues were what to do with people who needed kidney dialysis. Now, this is a really expensive treatment program, and initially there were not enough machines for the amount of patients, as well as kidney transplants. So what they did is they put together these committees. They were called God committees because these were the committees that determined who would get the kidney dialysis or who would get the kidney transplant. This went along with the End-Stage Renal Disease Act of 1972, which said that the state and the government would pay for people who had end-stage renal disease, which was very expensive treatment. And then because there was a shortage of organs for transplantations and there was controversy, how would these be allocated? That was the purpose of these God committees, was really to discuss and work together to determine who would get treatment and who would not. All right, our next chapter is why the U.S. medical system needs reform. And so in the United States, medical costs have been rising more rapidly than general inflation. About 18% of our gross domestic product is to medical costs. It's the most expensive compared to all other countries. And this rising cost leads more to lack of insurance, which leads, of course, to worse health conditions. And the truth is, the end opinion here is that the U.S. is really not getting its money's worth. So why do costs rise? One is our population is getting older because of new medical technology, including prescription drugs. Our administrative costs are getting higher, so the hospital administration, the people running the programs. Because there have been a lot of malpractice lawsuits, that leads to higher insurance for doctors, which then, of course, the cost comes down and it's higher insurance for us, the people. There are financial incentives for medical providers, a fee for service. And then for a while, the patients were demanding the best, were demanding all the tests, all the treatments, and they did not care about price. And so in an attempt to control costs, there were price tied in the 1970s. And what this did was limit new facilities and technologies. You had to have a certificate of need to develop new technologies. There were incentives for providers, diagnosis-related groups. And in the 1990s, managed care came about as a way to attempt to control costs. And some of these approaches worked for a while, but none really controlled costs for the long term. So in the 1990s, we had this managed care, which led to the Health Maintenance Organization, which is an HMO group insurance. This acts as both an insurer and a provider, and it agrees to provide all required for a fixed payment. Physicians and other providers are on a salary, and the incentives are to limit access to specialists and technology. And there are incentives to provide preventive care. And so what happens is each person is assigned, or you choose a general physician. This is your primary physician that you work with. And if you have a special problem, let's say you have a mole on your body that you need to have looked at by a dermatologist, you are not able to go to a dermatologist. You need to first go to your primary physician, and he or she would be the one to determine whether or not you need to see a specialist, and they would have to provide a referral. The other type of insurance is called a PPO, a preferred provider organization. Now here, the patients do get to select what specialty or what specialist they see. They have their own general physician, but let's say the same example, I want to have a mole looked at by a dermatologist. I would then just look at the list of dermatologists that work within my insurance and select one to make an appointment. So the managed care backlash. So for a while, there was this idea of drive-through deliveries and drive-through mastectomies. And what that means is that I would have a baby and then all done, and I would then be checked out of the hospital. I was not allowed to stay in the hospital after delivery. And same for mastectomy. I would have my uterus removed, and then they would kick me out of the hospital. And so there were laws against this where there are minimum requirements for hospital stays after a major surgery or a birth delivery. There were also gag rules where physicians were not allowed to talk to the patients about what their health insurance would cover and not cover, and that made people outraged, as it should. So consumers' rights to sue HMOs for denial of care. So if my care is being denied, I have the right to sue to determine why it's being denied. There's also a loss of ability to manage care in a cost-conscious way. So while the purpose of this was really to reduce costs, while it did it for a while, it was not in the long term, and then began to rise again. Not only did prices begin to rise, but also the number of people who were uninsured began to rise, which led to the Affordable Care Act. And so some of the provisions under this act said that children can stay on parents' insurance plans until the age of 25. Many preventive services were now free to insured patients. Medicare prescription drug coverage more affordable. And states can opt to receive federal funds for the expansion of their Medicaid programs for the uninsured. So there were also regulations, this individual mandate saying you must have health insurance or you must pay a fine. Large businesses must pay assessment if they don't insure employees. Large businesses would essentially get fined if they don't provide insurance to their employees. One of the backlashes of that is that it was large businesses must offer health insurance to full-time employees, not part-time. And so what we saw is a lot of movement from large businesses to reducing the number of full-time employees and employing part-time employees. And then health insurance companies were not able to have lifetime limits on health coverage. They were not able to cancel the policies of patients when their medical costs rise. They were not allowed to spend too much on administrative costs or to have a large profit margin. And one of the other big ones that's not listed on here is they also were not allowed to deny coverage of a person who has a pre-existing medical condition. So the Affordable Care Act brought on these insurance exchanges where it allowed for insurance companies to put their information on this exchange where individuals and families can purchase their own health insurance and compare costs. If you've ever gone to the health insurance exchange and put in your information, what you will find is that some of these insurance plans are very expensive, and so I still feel that they are cost prohibitive. There's also the Center for Medicare and Medicaid Innovation, which is a research center to improve the quality of healthcare and reduce costs of healthcare. All right, Chapter 28 are health services research and finding what works. And this is brought on by something called small area analysis. And what they find is that there are large variations in practice style by geographical areas. So the services that are provided in New York City are very different from the services that are provided in Savannah, Georgia. And this is true of many medical conditions out there. There are more variations for conditions on which evidence for appropriate therapy exists. Now that's interesting. If there's evidence that appropriate therapy works, why would there be such large variations based on where you live? Sometimes, however, more than one therapy may be appropriate, and this is where you would expect to see some variations. We have something called a Field of Dreams effect. And if you've ever seen the Field of Dreams, which I realize is an old movie, the basic premises is if you build it, they will come. And so what they found is that when there is an availability of services, it leads to more use of these services. For example, in an area that has more back surgeons, more back surgeries are performed. In an area that has more hospital beds, there are more hospitalizations. When there are more hospital beds, more patients die in a hospital rather than at home. Evidence in some of these cases that financial considerations may also affect medical conditions and decisions. So there's something called outcomes research, and this is an epidemiologic study of medical care. And analyses of data is generated by everyday practice of medicine. So they'll look at, for example, Medicare records. And here's an example. There is a condition in men called benign prostatic hypertrophy. There's a lot of variation. And so the idea behind this is if a man is diagnosed with BPH, should it just be watched, or should he undergo a prostatectomy, meaning the removal of the prostate? What they found is that when doctors are talking to patients about the prostatectomy, the benefits of this surgery and procedure are overstated. The complications are understated. Patients need to be informed adequately so they can choose the best possible procedure for themselves and make it an individual decision. Another example is this idea of the PSA screening for prostate cancer. This PSA screening leads to more invasive tests. So if something irregular shows up, then the next level of test is performed. However, there has not been evidence that having these more invasive tests reduce mortality from this type of cancer. Therefore, we have the Agency for Healthcare Research and Quality. This is mandated by Congress to develop guidelines for treatment in 1989. However, when the agency recommended less back surgery in 1994, the political pressure from back surgeons almost forced the elimination of this agency. The agency has now recovered, but it continues to show the political pressures when we talk about the medical system. And so this agency still has an interest in improving medical outcomes while controlling costs. But again, it just goes to show that there are many influences in what is determining the appropriate medical treatment. We look at medical errors. These include medication errors, wrong side surgery. So instead of having my right shoulder done, they did the wrong side, they did the left surgery. Its estimated errors cause anywhere between 44,000 to 98,000 deaths per year. And the system is decentralized, it's fragmented, there's poor communication, and so there is a continued interest to improve this communication. Recommendations to help reduce medical errors are to create a center for patient safety, to set national goals, track the progress, and do research. Errors should be reported and investigated. And then to reduce drug and medication errors, to do drug naming, packaging, and labeling to change so there's minimal confusion between medications. Also, to have a medical care report card. And when we look at this, managed care plans are much easier to evaluate than other plans because the data is readily accessible. There's accreditation of managed care organizations, and also there are annual reports. So you can evaluate the quality of care for some procedures. For example, the New York State measures outcomes for coronary surgery. These report outcomes for both individual hospitals and for surgeons, and the reports led to improvement in outcomes. And what they found is that surgeons that have high volume, lots of patients, did better, and hospitals did better. So it shows this is an effective way to help minimize or reduce deaths or disability due to medical errors. We look at inequities in medical care, and we've talked about this quite a bit throughout the year. But medical care is really rationed by the ability to pay. Who can pay for medical care? There are racial inequities in care, even when the ability to pay is the same. Black and Hispanics receive poorer treatment for many conditions, and an example is they are less likely to be recommended for mammograms, just one example. And the Institute of Medicine report said that there is bias, prejudice, and stereotyping in medical care. So again, the relative importance of medical care for public health. So it shows international comparisons show that health is proportional to wealth. So regardless what country you live in, the more money a country has, the better health outcomes they have. So the GDP is the gross national product. However, health is not proportional to the number of physicians. So the number of physicians has no impact on health. More spending does not improve health and may even increase mortality, which is the death rates. And so here you have conflicting data, right? You have these international comparison numbers that show the richest countries have better health outcomes. But then you say, well, more spending does not equate to better health outcomes. And so you have to really look into this idea, well then what does impact health? Money is involved, but how is money involved? And there was this experiment called the Rand Health Insurance Experiment. And it said that it found that for people with generous health insurance, that many of the healthcare services may have been wasted, meaning that they were having healthcare services that were not necessary. On the other hand, for poor and chronically ill people, having free care did not improve health status. And so it's important to really look at different options and ways to manage health to have the most benefits. And this brings us to our last chapter for this week, which is public health and the aging population. The average age of Americans has been increasing for a while. The baby boomers have retired. They're getting older, they're living to older ages, and as you can imagine, older people tend to have poorer health outcomes and require more medical care. This growth of cost in Medicare is unsustainable. It cannot continue the way it's going. And then the quality of life in later years really depends on lifestyle as youth and middle age. So trends of the aging population. Just to show about life expectancy, it has increased from 47 in 1900 to 78.5 in 2009. The cause of death in the elderly are similar to causes of death in overall population. When we look at the health statuses, when we look at young old, which are ages between ages 65 to 74, 82% are in good, very good, or excellent health. That's a great number. When we look at the aged population, which is between the ages of 75 to 84, 76% are good, very good, or excellent health. That's, again, a great number. Our oldest old, which are ages 85 and older, 69% are considered good, very good, or excellent health. 12% live in nursing homes, and this is the fastest growing age group, our elderly people aged 85 and older. And so as we live closer to the biological limit of our lifespan, right? So we have 80s and 90s. You have to think about what type of life is this. Does longer life mean that we have more years of healthy life, or does it mean we have more years of chronic disease? There is some evidence, however, to suggest that our older people are healthier than they have been in the past. So here are some factors that affect health in older age. Smoking. This causes a variety of different diseases and cancers, but you do see the prevalence of smoking decline in older people. Diet and physical activity is probably the #1 area that we can continue to work on and improve amongst our older population. Obesity causes cardiovascular disease, cancer, diabetes, arthritis, but the good news again is that the prevalence of obesity declines in older people. And so here when we talk about medical care, we really need to focus on secondary prevention, right? At this age, it's too late to really prevent any disease. But it's time to catch the disease early on so we can prevent it from getting worse. So preventing disease and disability. So we give all people the opportunity to have immunizations against pneumonia and influenza. For their older populations, this is really important to get those immunizations. There's also more medication available. So our older population obviously takes more drugs for many more conditions. However, they metabolize drugs very slowly or more slowly than they were when they were younger. And there's also a risk of drug interactions. Osteoporosis is having fragile bones, more common in women and as women get older. However, the risk of breaking bones leads to disability amongst older people. And so it's important to reduce the risk of falls in the homes of older people, especially if they have osteoporosis. To reduce falls is to reduce disability later in life. Also, as you get older, there is a vision and hearing impairment. Sensory loss leads to social isolation. If you have the inability to hear the conversations around you, you really feel left out of conversations and out of social circles. There's a higher increased risk of glaucoma, diabetic retinopathy, macular degeneration, cataracts from exposure to sunlight, and then again, hearing loss from exposure to noise all your life. In terms of oral health, there's tooth loss, periodontal disease, and etc., which may lead to social isolation because of embarrassment of having missing teeth or teeth that are in poor health. Medicare does not cover dental care, eyeglasses, or hearing aids. Also, I can tell you regular insurance, while it may cover some dental care, eye or vision care, it's very minimum. And then we also, as people tend to age, we have the increased risk of Alzheimer's and other dementias. The risk increases with age. It puts a huge burden on caregivers and family. It's estimated to cost more than $200 billion per year in long-term care. There is research that's beginning to give clues on risk factors, but there's no cure to date. Some medications may delay the progression, but none have been known to stop it or cure it. But even delaying the onset by a few years can significantly reduce the financial burden, but also the personal burden of people having to care for their parents or grandparents and so forth. The medical costs of the elderly is estimated to have more than doubled since 1966, which is way quicker than the cost of inflation. So the cost per enrollee is rising even faster than general health care, which, as you know, is rising. More costs are being shifted to the individual, so the person is responsible for the cost to their health. Medicare does not pay for long-term care, but Medicaid does, and that puts a lot of strain on state budgets. Changing in family structure means families are less able to care for elderly relatives. With both parents working and trying to manage a household, it puts an additional stress on families. Really, the hope is that our baby boomer population and our retiring population now is healthier than those in the past to help reduce healthcare costs. This concludes our PowerPoint for this week. I hope you have a wonderful week, and as always, let me know if you have any questions or concerns.